So I'd like to introduce you first of all to our next speaker for the afternoon, Professor Stewart Mercer, who many of you will know. Stewart is a GP and Professor of Primary Care and Multimorbidity at Edinburgh University. And from 2014 until March of this year, he was also the Director of the Scottish School of Primary Care. Stewart has been described as the David Livingstone of general practice research by Graham Watt, exploring the dark forests of the deep end for the last 20 years. And he is going to talk to us about the research evidence for addressing the inverse care law in Scotland. Thank you, Stewart.
Great. So thanks. Thanks very much, Carrie, and thanks for asking me to speak. I'll try to stick to time. It's the first time, and probably the last time in my life, that I'll be the warm-up act for Darren McGarvey. So I don't have such high expectations of me. I'm a great fan of Darren's work and his television series, so I'm delighted to be sharing this platform with him. Okay, so I'm going to talk a bit about the research evidence underpinning the inverse care law. Some of that's been touched on by Graham and Katrina. I just want to kind of go into a little bit more detail about it because I want to make a bit of a point about this type of research. Can I have the next slide, please? And just very briefly to say, a huge thanks to the people on this slide, in particular Graham Watt, who was my boss, my line manager, my mentor for over 20 years when I was in the Glasgow department, initially face to face, eventually I hope side by side. But Graham's been the driving force behind the deep end, of course. The deep end GPs, many of whom I've got to know and worked with and feel part of, and that's been a great privilege. Julian himself and of course his wife Mary and son Ben, who I think are with us. Julian was my absolute hero, still is, and a great inspiration. I just want to mention very briefly Bridie Fitzpatrick here, one of the unsung heroes of primary care research in Scotland, and without Bridie's help, many of my projects would never have come to completion. Next slide, please. So just to say, I'm going to focus, I've got 20 minutes, so I'm mainly going to focus on the research I've done. So apologies for that, because there's lots of research that is going on and is being done but in Scotland and in England. We're delighted to have Bex Fisher here from the Health Foundation on the panel. She's been doing fantastic work with colleagues on the inverse care law in England. Work from deep end academics like David Blaine, Andrea Williamson, Marion McCallum, and all the early year, middle grade and senior researchers in Scotland, far too many to mention. So, I'm going to focus on the stuff I know best, which is what I've done over the years. I started out, and I remain focused on this approach, a holistic approach to care. That's really why I became a doctor. And through medical school and medical training, we get taught all about the tip of the iceberg, the clinical gaze. But of course, to be a good doctor or healthcare professional, particularly a GP, you need to get beneath the surface and into the human story if you're really going to make any difference to someone's life, other than just dishing out pills. Next slide, please. So I started out way back in 1998 when I joined the Glasgow department, when Graham was head of department, thinking about and trying to look at ways, how could we measure some of this human stuff, what people call the human factor. For me, it boiled down to compassion and empathy. And I set about developing a measure of empathy from the patient's point of view, a patient-rated experience measure called the CARE measure. And that was really to try to give us a handle on the patient's views on consultations with GPs and other healthcare professionals. Next slide, please. And we used the CARE measure along with a number of other validated measures in a couple of studies. That was over about a 5 or 6 year period from 2000 onwards. The study on the left was completely done by patient questionnaire. We had patients filling in information about their expectations of the consultation with the GP just beforehand, and also about their experience and outcomes straight after the consultation. And we did this in 26 different practices, 16 of them in deep end areas, and 10 of them in affluent areas of the west of Scotland. And we collected more than 3,000 questionnaires. And the reason that Graham and I are the only two authors on this paper is that I was the foot soldier, I was a junior researcher at the time, and I did it basically all myself in terms of collecting the data, printing out the questionnaires, getting them picked up, and so on and so forth. That was a really good learning experience about how difficult it can be and time-consuming to do this sort of research. The second one was a much more well-funded project. We had funding from the Chief Scientist's Office. And in this study, because people were quite critical of patient views back in those days, it was like, well, how can you trust what a patient says? I think nobody would dare say that now. We thought, well, let's compare what patients say with what actually happens in the consultations. So we videoed nearly 700 consultations, about half of them in deep end practices and about half of them in affluent areas. And then we also collected the patient's views as before. And this time we measured the change in outcomes a month later. And this was the largest study of its type in the world then. I think it probably still is now. And it was a whole team of us working on this, but it was a huge amount of work and was only possible because of the cooperation of the patients and the GPs. Next slide, please. So what did we find from these two studies? And some of this has been alluded to, but I'll just go through it again. The patients in the deprived areas, in the deep end practices, compared to patients in the more affluent areas, had, press the button, more problems to discuss, which were more often complex, not surprisingly, because these problems were a mixture of physical problems, mental and social. Press again and again. The consultations were shorter by about a minute. And again, the GPs were perceived as less empathic than GPs in affluent areas. Again, on the objective analysis using these validated ways of analysing patient-centred care, the consultations were less patient-centred. And again, the outcome of the consultation, patients felt less enabled, less able to cope with their illness and look after themselves than in affluent areas. And again, and the outcomes at one month after the consultation in terms of symptom progression and overall well-being were much worse in deprived areas than affluent. And again. And we asked GPs to record their stress level on a 10-point scale after every consultation, and we found that the GPs in deprived areas were significantly more stressed than the affluent GPs, affluent areas. And that, in a nutshell, was filling in the swimming pool, if you like. This is really how the inverse care law operates in deprived areas. That was the case back then. I doubt it's changed much now. And I was very happy that Julian sent me one of his lovely postcards, which he drew himself and sort of congratulated on that study. And it's still one of my prized possessions. Next slide, please. The other thing out of this video study, because we had the outcome measures a month after the consultation, we were able to look at the factors that predicted better outcomes, both for symptom improvement and well-being. And what we found out of all the different factors, I mean, many of the patient's factors, such as age and poor health and so on, predicted outcomes. But in terms of the things within the consultation that you could change, if you press it again, please, Mark. The key thing that predicted better outcomes, in fact, it was the only thing that predicted better outcomes, was the patient's perceptions of the GP's empathy using the care measure. And that predicted both patient enablement. We never had high enablement with low empathy. And it also predicted better health outcomes at 1 month in both deprived and affluent areas. So it seems that this relationship, these human factors, are absolutely central in deep end areas as well as affluent. And actually, now there's very interesting new evidence from Cambridge, from Ajira Damba-Miller, who's looked over a 10-year period at care measure at baseline and outcomes at 10 years. And she's actually found a reduction in mortality in people who rate their GPs as empathic. Next slide, please. Then things all changed. About 2009, I managed to get a large grant from the Chief Scientist's Office, a project grant. It was a one-off. They've never repeated these since, but they were, I think, very successful. A number of people got them in Scotland, and I got one to look at multimorbidity in relation to deprivation. And this paper came out of that. It was a big data analysis of multimorbidity across Scotland. Next slide, please. And we published this in The Lancet in 2012. It's probably the simplest paper I've ever done in terms of analysis. Yeah, it's the one that's most highly cited, more than 3,000 citations now. So it does show you what you can do with big data. But what it shows is as people get older, everyone gets some degree of multimorbidity. But in the more deprived areas in dark red, that's the most deprived decile in dark red, compared with the most affluent in dark green, there's a 10 to 15-year gap. So people living in deprived areas develop multimorbidity 10 or 15 years younger than in affluent areas. And of course, this contributes to the inequalities that Sir Harry Burns was talking about. And when I talk about multimorbidity, we included addictions, alcohol misuse, mental health problems, 8 different mental health problems, 32 physical conditions. So it's a broad brush approach. Next slide, please. And why is multimorbidity important? Well, it's not very good for you. It kills you. The more conditions you have, the more likely you're to die. So if you get a lot at a young age, that will lead to higher premature mortality. Again, it gets you into hospital. Graham alluded to this, especially unplanned admissions. So the more conditions you have, the more likely you'll be admitted to hospital, not surprising, but this is vastly increased by deprivation and by mental health problems. And again, it massively reduces quality of life. So the more conditions, the worse your quality of life is. And this is particularly true in deprived areas. So for a given number of chronic long-term conditions, the impact on quality of life is higher in people living in deprived areas than people living in affluent areas. And again, so for all of these things to do with multimorbidity, it's worse in deprived areas compared with affluent. And next slide, please. So to go back to the consultation, which is the thing I kind of started with, we wanted then to say, okay, what happens with multimorbid patients within consultations in deprived and affluent areas? And we looked again at this video data set. And what we found, next slide, please, is that if you look in the affluent areas, then patients with multimorbidity compared with those without, that's people with 1 condition or 0 long-term conditions. In the affluent areas, the multimorbid patients had consultations which were longer by 40%. The patients perceived the GPs to be more empathic, and the GPs were more patient-centered in those multimorbid consultations than in non-multimorbid. And none of these differences were found in the deep end. So for the multimorbid patients in the deep end, they're kind of treated like everyone else, and that's because there's so many of them, and the GPs are struggling to keep their head above water. And the biggest difference between deep end and non-deep end is in the outcomes of the multimorbid patients. They're the ones who are suffering most in the deep end. Next slide, please. And even at this point, when I would be giving these talks, there would be sometimes a bit of an air of indifference, not by GPs in the deep end, but by other people. I'm not going to name names. So what? We know this, Stewart. You know, deprivation, inverse care law, it's all about the social determinants. This is what you'd expect. You can't change it. So next slide, please. I always like a challenge. So we set about trying to show experimentally if you can reverse the inverse care law in deprived areas with these multimorbid patients who are the deep end of the deep end. Can you actually show it make a difference? Next slide. And this led on to the Care Plus study, which I led with Graham and many other colleagues. Next slide. And we developed a whole system approach, as we called it, a complex intervention. At system level, we gave the practices who were in the Care Plus group, we did it as a cluster randomized control trial. So some practices got this and some didn't. The ones who got it had longer consultations for selected multimorbid patients over the course of a year with continuity. So the same GP or nurse saw that patient for 12 months, and at the first consult, and the consultations were substantially longer than the usual 10 minutes. The GPs then had support meetings that we provided, and we gave them a structure for these consultations that they could use called the care approach, based on an empathic, patient-centered approach. And then we also gave the GPs, the patients, additional self-management support in the way of mindfulness CDs, stress management techniques, and so on, which we gave that to the GPs and they could pass that on to the patients. Next slide. And the first challenge was really, could we actually get practices and patients to take part? This sort of work hadn't really been done. And we recruited 8 practices really very easily. And we recruit each arm of the intervention, recruited 75, 76 patients. We collected baseline measures before we randomized the practices. And then at 6 months, we had follow-up rates, and the follow-up was all patient rated in terms of outcomes. So we had to go to patients and get the questionnaires filled in and so on, of 90% at 6 months and 88% at 12 months. So this is gold standard in terms of a cluster RCT. And it was a huge amount of work on the part of the team and Bridie, but it shows it can be done. Next slide, please. The consultations were longer. They were delivered substantially longer, 35 or 40 minutes for that first consultation. Patients were very satisfied. Next slide. The patients saw the empathy of the GPs as higher, and they felt more enabled. Next slide. And at 6 months in the Care Plus group, quality of life improved a little bit, and it decreased in the control group. Next slide. And at 12 months, all of the outcomes which were around well-being and quality of life shifted in the direction of Care Plus, and a couple of them were highly significant. So we were able to show improvement in well-being and quality of life. Next slide. And I think one of the exciting things for me also was that it was massively cost-effective. It cost more money, of course, but it was cost-effective, well below what the UK government currently supports through NICE as being a cost-effective intervention. Next slide. So, and again, and again, and again, and again. So I'm going to go quickly because I'm running out of time. In a nutshell, we know that the inverse care law works by limiting what practitioners could otherwise do. We turned that on its head in Care Plus, and we found evidence of effectiveness and cost effectiveness. Next slide. But the question in the last minute or so is, hasn't it all changed? We've got all these new reforms, we've got a GP contract in Scotland, and so on and so forth. Next slide. And then press again. And again. And again. And there's a whole host of questions that we need to ask. The deep end, actually, not most deprived patients in Scotland are not in deep end practices, but are scattered elsewhere. We know very little about them. We know very little about the new model of care, how that will affect inequalities. How do we mitigate the effects of the pandemic in deprived areas? How do we retain and rebuild the workforce? So there's a lot more to be done. And most of these things I've listed are not well evidence-based at present. Next slide. I think holistic care needs holistic research. And the sort of research I've shown you requires co-production with GPs and patients. And it's very time-consuming and painstaking, and it takes much longer. And funders generally don't recognize that. Next slide. And again. So we need funding to do such research on the English School of Primary Care. I have to get this dig in. I'm afraid 9 universities just been awarded £32 million from the Department of Health for the next 5 years, building on 20 million in the last 5 years. Big smile for them. Scottish School of Primary Care, 9 universities. We've got £50,000 for the next year. We don't know after that. To be fair, we did have 1.25 million back in 2016, but that ran out. So if Scotland is to keep ahead of the game and compete in much needed research, we need funding to do that. Next slide. Julian's words, as Graham has said, sadly as relevant now as 50 years ago. Next slide. And there's much to do. Thank you.